Hello, everyone. It's 7 o'clock. Welcome one and all to the 2022 series of patient, family and family forums on bone marrow failure syndromes hosted by Maddie Rewalt's Vision and the Centre for Research Excellence in Bone Marrow Biology. My name is Dave Ritchie. My absolute pleasure to be here with you tonight and welcome you all to this most excellent lineup of speakers who we will all hear great insights into how to try and make the journey of bone marrow failure that little better understood, a little more comfortable, and looking forward to the future with new developments. Before I start with introductions and so on, I think it's always important to say thank you to the people who are hosting us as visitors to their land. And by that I mean I would deeply like to acknowledge the traditional owners of the land on which we meet. And because this is a virtual forum, we're meeting from all around the country. You may even have some international visitors to our sessions tonight. And if you all just take a moment to say a quiet thank you to those traditional owners, wherever you might be, for the opportunity to live in such a great place with so many great opportunities and facilities. I would like to pay my respects to the elders of those traditional owners, past and present, and to any of the elders of other communities may be joining us today. And thank you for joining us if you are, and thank you for hosting us here in your country. So I'm Dave Ritchie, as I mentioned. I'm a haematologist and a translational researcher at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. And it's my distinct pleasure to be the director of the Centre for Research Excellence in Bone Marrow Failure Syndromes, which is a key research strategy undertaken by Maddie Rewalt's Vision, really almost since its inception. What is the CRE? The CRE is essentially a gathering of all of the researchers, young and old, experienced and emerging, who have a single focus, that is to make the lives of patients with bone marrow failure syndromes better through research, through identifying mechanisms by which treatment can evolve and be delivered in a safer and more effective manner. Myself, the Rewalt family and the founding board members were proud to establish MRV now over 7 years ago. And we now support over 30 projects, young investigators, clinical trials, and some of the research you'll hear about tonight and in subsequent meetings. But fair to say that we received very clear instruction from the Rewalt family at the very first meeting that we had all those years ago, that every dollar raised was to be spent on research to try and improve the lives of patients with these cluster of terrible conditions and to help their families understand the journey and to provide better care. So you will hopefully have seen the lineup for tonight, and we're really delighted to have so many excellent clinicians and researchers joining us in this first of 4 symposia. And I'm going to bow out fairly soon after these introductory comments and leave you in the hands of Dr. Lucy Fox, who will be the chair for our proceedings tonight. But before we move on to Lucy, I would like to introduce you to the chair of the MRV board, Ed Kemp, who has joined us tonight. Ed, as I mentioned, is the chair of the board. The board is a dynamic and highly experienced and highly talented group of people, and they even allow me to sit on the board as a mark of their generosity. The board have a single focus of integrity in research, integrity in fundraising, and understanding that behind every donation and behind every project, there are patients and their families. It's very generous of Ed to say a few words on behalf of the MRV board and executive. And so, Ed, handing over to you. Thanks very much.
Thanks, David, and good evening, everyone. As David mentioned, my name is Ed Kemp. I'm the chair of Maddie's Vision, and on behalf of the board and executive team, thank you for attending this evening's in the 2022 Patient and Family Forums. I too, as David said, would like to acknowledge the traditional owners of the lands on which we are meeting this evening right around Australia. We're proud to again provide you the opportunity to hear from experts in bone marrow failure syndromes, with thanks to our Centre of Research Excellence in bone marrow biology. In creating this year's forum, we've taken on your feedback, providing multiple sessions on specific diagnoses and hosting these sessions in the evening. We hope these modifications to the program prove to be helpful to you all. As you would appreciate, an enormous amount of work goes into organising these forums, and I'd like to thank Professor David Ritchie for his tireless work with the Centre of Research Excellence, Dr. Lucy Fox, our Maddie Rewalt's Vision Bone Marrow Failure Research Fellow, who again has chaired the organising committee, the following members of the organising committee: Professor Tracy Bryan, Dr. Paddy Barbaro, Dr. Adam Nelson, Dr. Parvathy Venugopal, Dr. Belinda Goh, our patient advocate Judy Edwards, and the Maddie's Vision executive team, who have worked tirelessly over the course of the last couple of months to bring tonight together. We're delighted and proud to present to you a program designed to keep you informed and updated about the latest research and treatments in bone marrow failure syndromes. A time for Q&A will be held at the end of each weekly session, so please submit any questions you may have to the chair, who will endeavour to answer them. Maddie's Vision is continuing to honour Maddie's legacy by filling a void and providing comfort. We are committed to our telehealth nurse service and are currently planning to expand the service nationally. We have come a long way in just over 7 years, but we still have so much work to do. To every patient and family member, we at Maddie's Vision have got your back. We are committed to ensuring that every dollar we raise is directed towards a better understanding of bone marrow failure syndromes, and we will leave no stone unturned in our quest to find better treatments and hopefully a cure. Thank you all for attending our third Patient and Family Forum, to being part of our community and to helping keep Maddie's light shining. Thank you all. I hope you enjoy the sessions and get plenty out of them. And I will now hand over to Dr. Lucy Fox. Lucy.
Thank you for that, Ed. Good evening, everyone, and a big welcome to this first session in our 2022 series of Patient and Family Forums. My name's Lucy Fox. I'm a haematologist. I work at Peter MacCallum Cancer Centre, Royal Melbourne Hospital, the Austin Hospital, and also Monash University at the Aplastic Anemia and Other Bone Marrow Failure Syndromes Registry. I'm chairing the session tonight. I've been grateful to work with the Maddie Rewalt's team over the last couple of years on several projects and events, and I'm very grateful to them for their support. We have a great program for you tonight. We had originally casually entitled it as the Spring Series. It's lining up with the Spring Carnival in Melbourne, but the weather really in Melbourne is anything but spring-like at the moment. I'd like to, before I start with my talk, I'd like to thank our sponsors. In particular, I would like to acknowledge the Victorian State Government, whose generous funding allows Maddie's Vision to hold these forums. We'd also like to thank our platinum sponsor for this evening, which is Alexion, and our gold sponsor for the Q&A session at the end, Servier. I'd like to thank our honorary sponsors who are generous supporters of Maddie's Vision throughout the year, Dexus, Carmen's Kitchen and Flavorite, and we're most appreciative of their support. A couple of housekeeping things. We have a range of expert speakers tonight, and we're going to defer questions until the end. All our speakers will stay online until the end, but please do submit your questions along the way via the Q&A icon. You can do this along the way, you can do it, but you can identify yourself or you can submit questions anonymously if you like. As the chair, I'll see all the submitted questions and we'll make every effort to get to them at the end of the evening. Depending on the time and the volume of questions, we may not get to all of them, and if that's the case, I apologise in advance. So I'll be the first speaker this evening. And please bear with me for a second while I share my screen. Okay, so it's a real pleasure to speak to you all today about this topic, which we have been really immersed in at Peter Mac and Royal Melbourne over the last couple of years, and beyond Peter Mac and Royal Melbourne. We've made so many advances in the last couple of years in collaborations and in research programs. Genetic testing has come a long way. And we're really seeing how the improvements we're making are being translated into meaningful benefits for patients and their families. But there's still much to discover and improve on, and every day we focus on how we can do this. We believe the registry, the biobanking, collaborating with our colleagues nationally and internationally will permit us to do this. So I'm speaking to you tonight on a brief overview of the bone marrow failure syndromes, the registry and the biobank. So to start with, I want to explain what I mean by bone marrow failure syndromes. We think about the bone marrow as our blood-making factory. It's an organ. It produces the red cells, the white cells, the platelets that we need for everyday living. On the left here, you can see a normal cellular bone marrow that's capable of churning out those blood cells. And really, we never want to see a bone marrow here on the right, one that's empty and incapable of producing those blood cells that we need. So what are the bone marrow failure syndromes? I think it's important to have a good appreciation of what the diseases are before we start all the wonderful talks we've got for you tonight. So I want to explain to you the different diseases and why we consider them under the bone marrow failure syndromes umbrella. So firstly, we have acquired aplastic anemia, particularly immunoaplastic anemia, which occurs when the immune system attacks the bone marrow compartment, or sometimes there's a virus or something else that's triggered destruction of the bone marrow. So this, in most cases, this is not considered to be an inherited disease. Secondly, we have the traditional bone marrow failure syndromes. These are some somewhat confusingly named eponymous syndromes, Fanconi anemia, dyskeratosis congenita. And these are diseases we've known about for a long time, but we've been making these diagnoses better in recent years because we have excellent access to genetic testing. And these conditions are considered to be inherited or germline. And then finally, we have the new kids on the block, this inherited predisposition to hematological malignancy or blood cancer. And there's some genes are listed there, and this is an ever increasing list. These are diseases which have only really been known about in the last decade or so, some even in the last few months. And so these conditions are inherited, or the other word for that is germline. So why do we consider these diseases together? Firstly, patients can present the same way with symptoms due to low blood counts. And when we do a bone marrow biopsy to investigate these low blood counts, the diseases can have the same hypocellular or empty appearance down the microscope. So doctors need to have all of these things on their list of potential diagnoses when they're trying to pinpoint the diagnosis. We lump them together because some aspects of treatment are the same. All of these conditions may be treatable in the right circumstances by a stem cell transplant. And a final unfortunate thing that ties them together is that most of these conditions, virtually all of them, have an increased risk of developing a blood cancer. And the level of risk varies across the diseases. It's quite small in acquired aplastic anemia, but it can be more significant depending on what gene is causing an inherited bone marrow failure. So we go to great lengths to try to pinpoint a patient's diagnosis. If a patient has immunoaplastic anemia, it can be quite tricky to find the diagnosis, but we have several tricks in order to do this. But on the inherited side, as I said before, in recent years, we've got many tools available now to try to pinpoint a genetic or an inherited diagnosis. And there's several reasons why we want to do this. So firstly, it can confirm the diagnosis. We know that it can be very difficult to make a diagnosis from the end of the bed or with the traditional testing available. So genetic testing can really nail what's going on. It may provide prognostic information. And it means if we can find a mutation in a patient, it means that we can easily and fairly cheaply test for the mutation in other family members, both for treatment, and that can help treatment of our patient, but also may help with their other family members' health. So if a patient with an inherited bone marrow condition requires a stem cell transplant, we want to make very sure that a family member doesn't have an inherited mutation that they can that might cause unwanted bad effects in the setting of a bone marrow transplant. And so we quite commonly can test, and we quite commonly test family members to make sure they do not have the genetic mutation that's causing troubles in their family member. It tells us the patient's chance of having a genetically affected offspring. And it lets the patient consider some fertility options. And you'll hear more about this in a talk later tonight by Laura. So I want to mention to you now a project called we nicknamed the Registry, so the Aplastic Anemia and Other Bone Marrow Failure Syndromes Registry. This is chaired by Professor Frank Birkin, and it's overseen on a day-to-day basis by Professor Erica Wood at Monash University. So the registry has been running since 2013 and in recent years has had the wonderful support of Maddie Rewalt's Vision. In 2020, we changed the name of the registry, and it's long been open to patients with all kinds of bone marrow failure syndromes, but the old name of Aplastic Anemia Registry meant that really virtually all of the patients we were having enrolled were patients with immunoaplastic anemia, and we wanted to ensure we could include all the traditional bone marrow failures and the more recently described inherited bone marrow failures. And we want to examine where patients are, what treatments they're having, what their outcomes are. And it's a critical resource for us because there will be over the next decades really exciting, novel, expensive therapies for patients with bone marrow failure and I mean inherited and acquired diseases. And to bring these treatments to Australian patients, we need to know where the need is. If we have a treatment, for example, for Fanconi anemia patients, it would be wonderful for us to turn around and be able to say to a drug company or other company interested in sponsoring a trial, you know, we know exactly where 20 or 30 patients are in the country who could benefit from these therapies. So we are really keen to have every Australian patient enrolled in the Aplastic Anemia Registry. And you can see here the sites right around the country where we are currently enrolling patients. And so patients on the line, I would encourage you to speak to your doctors about whether you have been enrolled in the registry. Hopefully you have, and if you haven't, you can ask for a copy of the brochure and we'll get you enrolled in it. And here is a picture of the accrual of the registry. So over the time, we've now got up to 303 patients enrolled in the registry. So we want this graph to keep going up because we know there are many more Australian patients that we haven't yet captured with bone marrow failure syndromes. I'll skip that. And so I want to advertise as well the biobank. This is coming soon. This is a collaboration between Biobanking Victoria, which is a long-established biobanking centre established by Melissa Southey, and we're linking that with the Aplastic Anemia Registry. So we'll have samples and clinical annotation of those samples with patient details of mutations and treatments and things all in the registry. So we hope this will be a powerful repository of samples and clinical data for clinicians and researchers to access when they submit projects for approval to access the samples. So there's lots of people who have been involved in the Maddie's Vision projects over the years, and I won't mention all of them, but I do want to acknowledge all patients and families who permit us to capture their stories in the registry, and hopefully one day the biobank. We really believe this is the way that we can move forward to improve treatments and outcomes for everyone in the future. So I'm going to stop sharing now. And I'd like to introduce our second speaker. Our second speaker is Yvonne Panic-Hudson. She is a nurse practitioner in clinical haematology, and she's the lead in our allogeneic bone marrow transplant long-term follow-up service. She's also the Associate Director of Nursing, Haematology and Medical Oncology at Peter Mac and Royal Melbourne Hospital. And today she's speaking to us about transitioning from paediatric care to adulthood, the TransAllo project. Thank you very much, Yvonne.
Thank you, Lucy, and thank you to Maddie Rewalt's Vision for inviting me to present tonight on an area of allogeneic transplant that's very dear to my heart and something I'm very involved in clinically. This project we undertook a couple of years ago, and we called it the TransAllo study, and it was a study where we looked at the factors influencing attendance at and experiences of a long-term follow-up clinic post-allogeneic bone marrow transplant for patients transitioning from paediatric to adult services. Okay, I'd just like to thank all of these people up front, obviously, most importantly, the patients and carers of the long-term follow-up service here in our integrated clinical haematology service across Peter Mac and the Royal Melbourne, our wonderful team, our project team on the TransAllo study, and also the sponsors of the TransAllo study, which was funded through the Victorian Comprehensive Cancer Centre. And led by a team, led by Mai Krishnasamy and her team. So, you know, I think I'm probably preaching to the converted in, you know, the knowledge that survivorship care is a really complex area, and it encompasses transitioning patients off their active treatment and providing support for rehabilitation and return to work, and planning for disease-specific and treatment-related follow-up, and also providing patients and their families.
Can I just stop you just one question, one quick second, sorry, it's Lucy. Are we supposed to be looking at your first slide at the moment?
No, you're supposed to be looking at my third slide, which I can see. Which one can you see?
We've got your presenter view. We don't have presenter view, so we're looking at your first slide and then all the slides on the left.
Really?
Maybe if you could just manually pull it down. You could just click onto the third slide on the left. Yeah, so maximize that.
This is very odd. Just give me one sec. Sorry.
That's okay. We can do it in presenter view. We can do it in the view that you had it. You'll just have to manually move through the slides.
So which one can you see now? Sorry, everybody.
A small version of the PowerPoint presentation. So just we've got the, so I think you should maximize it.
Yeah. So I've maximized it now. I'm not sure why, because it's full screen on my screen.
Okay.
Just give me one sec. What I might do is I might just stop sharing and start again. Is that all right? I won't start my presentation again, but I'll just start
sure thing
again. Screen share. Okay, what can you see now?
Yeah, that's fine. We can still see. Oh, yep. Just go through it like that. So we've got your slide background to adult service.
Yep, fantastic. That's good. And I can,
Now I've lost it. We've got your desktop.
how about that?
We've got your desktop.
Okay, I'm not sure what's happening. Just let me try again. Sorry, everybody.
I'm happy to step in, Yvonne, if you would like me to share my screen.
Because we did actually, we thought that just in case something happens that we would,
Well, that view we've got's fine, Yvonne, if you
Yeah,
can.
just
you've got that?
Yeah, I think that view would be fine.
How about that?
Yeah, you can, we can see all your content.
All right, brilliant. Apologies, everybody. All right, so just moving on to the next slide. So just to give you a bit of background to our adult long-term follow-up service. So we started our service in November 2014, and at this point in time, we've completed almost 2,000 individual patient reviews. So we're a really busy service. Patients are eligible to attend at 2 years post-allogeneic transplant, and all patients attend annually. In preparation for their long-term follow-up review, they complete a series of patient-reported outcome measures and patient-reported experience measures, which are really important, and we integrate into all clinical reviews. So we don't just collect that data and use it for publication, presentations and research. I mean, obviously we do that as well, but it's a really important part of our clinical consultation. Our consultations are an hour, and they incorporate a multidisciplinary approach to patient reviews. We have a nurse consultant who starts off the review with patients, and then patients either see one of our hematologists or myself for their review, which incorporates a whole of person approach with a physical, psychosocial, sexual health assessment. We assess late effects risks, and then we arrange screening, monitoring, referrals and education. Now, the need for the study became really clear with an increasing number of young people who were being referred to our service. But what we found was that the attendance rate of some of the adolescent and young adult patients who were being referred to us was not as good as the attendance rate of our adult patient population. And we wanted to understand that a lot more in order to improve attendance rates, but in order to ensure that we were addressing the needs both from a physical and a psychosocial and a supportive care perspective of our adolescent and young adult population. And when we did a literature review, we found that there was a real paucity of evidence-based information on how to best support young people during this transition from paediatric to adult care. So the aim of our study was to explore and describe the facilitators and barriers to first attendance at an adult allogeneic bone marrow transplant long-term follow-up clinic. And we broke up, what we did was we just didn't want to ask the one group of patients what their perspectives were. We wanted to understand it from a whole different perspective. So people who had not yet been referred to us but were going to be referred to us, patients who had been referred to us, you know, potentially years before, who had come to us as adolescents and young adults and who were now well entrenched in our service. We also wanted to understand why people were not attending. So we actually asked people who had never attended our clinic, although they'd been invited to attend, why they were not taking up the offer. So we wanted to understand the most common barriers and facilitators and utilise these to inform the future development of a toolkit for adolescents and young adults and staff to support transition from paediatric to adult bone marrow transplant long-term follow-up services.
Yvonne, what slide are you on?
Design and methods.
No, so we're on number 4. So I think we might just have to, could you use your mouse to go down to this slide on the left of the side so we can move forward? So if you're on slide 6, just click on 6.
So I am actually using my mouse, Lucy. Sorry.
Oh, I'm sorry.
Yeah, I don't know what's happening.
Well, this way is fine. We've just changed our view.
Okay, great. Thank you.
This will do. Yeah, thank you.
So essentially, we used a qualitative interpretive method in order to gain knowledge about individual participants' experiences of transitioning. So it was well and good for us to try and understand it from a healthcare professional perspective, but we wanted to understand the lived experience of transitioning from the adolescent and young adult population. And so we invited 20 adolescents and young adults to participate in semi-structured telephone interview. Can you see this slide? Themes from, so the themes that we derived from the semi-structured interviews were that adolescents and young adults see support as incredibly critical. They prioritise attendance at long-term follow-up clinic appointments. They see communication and education and knowledge as incredibly important. They recognise that transitioning is an emotional experience, not only for them, but for their carers, who were carers of them when they were children receiving treatment and undergoing bone marrow transplant. And that it is quite a significant experience for them transitioning, but the transition needs to be prepared for more intentionally and needs to be commenced prior to their transition. So what we also derived from the interviews were a number of really beautiful quotes from participants. I'm sorry if you can't see these, but the young adults and adolescents, they described their parents as storytellers and historians. One young person described their transition experiences. Dad just automatically phased himself out. Another young person said, it was a bit weird being 17 or 18 and attending at the children's, and then like in the waiting room, you're surrounded by little kids. Another young person said, I found a little bit of the continuity between the appointments and then the follow-up to be a bit out of touch. Another young person said it would have been good to get a little bit of a summary as well. So they meant before they left their children's treatment centre. Another young person shared, there was never a sense of doubt in my mind that I was going to go to my long-term follow-up appointment. And another young person shared, the adult one, I brought my mum along with me because I thought, I know nothing about my medical history. She knows everything and the doctor can ask her all the questions. Another quote was, I guess, just not assuming, but just asking the patient, has anyone talked to you about this? So this is about intentionally preparing people for transition and ensuring they have the right information and resources in order to do that in a way that is optimal for them. Another young person shared, so I was quite sad actually to leave it all behind really, you know, which is a bit weird considering, you know, a lot of times there weren't very nice things that happened, but I was really sad to leave. And another couple of final quotes, when I became independent moving away from home, I wanted to become independent in all aspects of what I had to do. And then this one I really liked. This young person said they knew it was time to transition to an adult long-term follow-up centre when they were the only one in the waiting room with their own car keys. So all of this formed the results of our study, and from that we made some recommendations, but we also acknowledged that there were some limitations in our small study, that it did not include carers' experience, although our young people who participated did talk about their carers quite a bit and acknowledged the impact on them and the experience for them, but obviously we didn't hear their voices in this study, and it didn't describe healthcare professionals or long-term follow-up team members' perspectives. So in conclusion, What we know is that adolescents and young adults experience challenges pre and during transition that impact upon their experience of and attendance at adult long-term follow-up services. So there are things that we needed to do better, and that transition requires attention to the needs of AYAs and carers and thoughtful preparation. So from all that, we came up with a series of recommendations which we've implemented into our traditionally adult long-term follow-up service. So we've included early discussions around readiness for transition from the paediatric to adult long-term follow-up services. So we've formed a closer relationship with paediatric cancer centres who are referring to us for patients transitioning, and having detailed conversations with those teams in order to ensure that the patient and carers are more ready for that transition to adult long-term follow-up. They are ensuring that the young person has more opportunity for discussion and greater accessibility to their personal healthcare information earlier, prior to transitioning to adult long-term follow-up services. And young people are provided with a survivorship plan or transition roadmap. Upon referral to us, we are interacting with them a lot earlier and providing them with both verbal and written information about our service, but really importantly, names of people within our service that they can contact if they have any questions, and our contact details. Where obviously, and COVID has contributed to this, but providing more flexibility in how we're delivering our services. But something that we've implemented is we have a dedicated AYA transition clinic, which we hold once a year, and will extend to twice a year starting next year. And really importantly, what we're taking on board is the importance of doing some further research, including carers, and also paediatric AYA and adult long-term follow-up teams. So that will form the next part of our work. So thank you for listening to my presentation. I apologise that my slides have not been visible to you. However, this study has been published in the Australian Journal of Cancer Nursing, and I've included the quote, the reference on the bottom of this slide. And that is my contact email address, and I'm really happy to take any questions at any time via email. And just a cheeky little plug there for our podcast, which is called The Straight and Marrow, which is everything about allogeneic bone marrow transplants. So that's available on Apple Podcasts and Spotify. Thank you.
Thank you. Thanks so much, Yvonne. And we got there in the end with your slides. We were able to see all the great quotes and the rest of the talk. So thanks so much for that. Please, a reminder to everyone to please submit some questions in the Q&A. I'm sure there's many people who have questions about transitioning to adult care, and please do submit them through Yvonne to answer at the end. So I'll ask Yvonne to stop sharing her slides. I'll ask our next speaker, Laura, to start sharing her slides. So Laura Bark is an associate genetic counsellor that I have the pleasure of working with at Peter MacCallum Cancer Centre in the Genomic Haematology Clinic. So she's an associate genetic counsellor who specialises in bone marrow diseases, and she's going to talk to us about family planning. So thank you very much, Laura. We've got your screen well. Thanks.
Perfect. Thanks, Lucy. Sorry, it helps if I unmute. Thanks, Lucy, for your introduction, and I'm really excited to be here today. So thank you to Maddie's Vision for inviting me along. So like Lucy said, I'm an associate genetic counsellor, and we specialise in bone marrow failure conditions here in the Peter Mac Haematology Service. And I'll be talking about the role of genetic counselling in family planning, in inherited bone marrow failure conditions. And I just really want to stress, and thank you, Lucy, very much for setting up my talk very well by talking about what is and isn't an inherited bone marrow failure condition, but this talk will be quite specific to those of you who have an inherited, not an acquired bone marrow failure condition. So I apologise if this might not be as relevant for you as you thought. So I just wanted to briefly start by talking a little bit about what genetic counsellors actually do, because our role can be a little bit elusive sometimes. So genetic counsellors have specialised training to communicate and explain genetic information, which I'm sure some of you are aware can be quite complicated. We provide information and options for genetic testing, and what those are specifically for family planning, I'll talk about in a little bit. As genetic counsellors, we also understand your individual story and that of your family, and can help you make the decisions around genetic testing that are right for you. And lastly, we provide support because we know that making testing decisions around genetic testing are not always easy. Before I talk about genetic testing and family planning, which I feel like as genetic counsellors we spend most of our time doing, I just wanted to briefly touch on fertility and pregnancy in inherited bone marrow failure conditions, because we know that sadly people with inherited bone marrow failure conditions can experience infertility and sadly also lose pregnancies. More research is needed into whether that is more common than in the next person, but certainly in our clinic we have seen these experiences, which is another reason why we specialise in support as genetic counsellors. And also pregnant women who have an inherited bone marrow failure condition might experience complications with their own health during a pregnancy, and that might require some specialised care during the pregnancy, which is why I've put there in bold that multidisciplinary care is really important to us, for you guys, during your family planning and your pregnancy. So getting to some genetic testing options, as you can see, there are quite a number of different options listed on this slide, and I will go through them, but I really want to point out that this is a very general overview. In most cases, if a person has an inherited bone marrow failure condition, there is a 50% chance that they could pass that on to any of their children, and their children will have that same condition. There are other inherited bone marrow failure conditions that are inherited in different ways, and so options may or may not be relevant depending on how the condition that you have or is in your family is inherited. So having said that, what are the options that you might have? So the first option, of course, and probably the most important one to empower you, is that you don't have to have any genetic testing at any point during or after your pregnancy for your child at all. But many people do want to know if their child could be affected, or even want to prevent passing on their condition that they have altogether. So one option to do that is to use IVF, which is a service where embryos that then go on to create the baby are created in the lab from you and your partner's own egg and sperm. And then genetic testing, or PGTM, can be arranged, and only embryos that do not have the genetic change that causes your bone marrow failure condition are used. So that is to avoid passing on that condition altogether. It's a lengthy process, and I really want to point out that the IVF specialists are the ones to talk to you about that, but genetic testing is not always guaranteed to be available. So if it's a process that you're considering, please come and speak to us or an IVF service. Another option is to conceive naturally, have a natural pregnancy, and then arrange genetic testing during that pregnancy. That usually can happen from around 12 weeks of pregnancy. It is an invasive procedure that is used, but the genetic testing results are highly accurate. And then, of course, if you find out that your pregnancy is affected, then you would have a very difficult conversation, very likely, about whether you'd like to end that pregnancy or continue that pregnancy. Now, if you want to know whether your child might be affected because they may need haematological care at a young age or for another reason, but it wouldn't change whether you'd like to continue that pregnancy or not, then you might consider genetic testing of your baby after it is born to avoid the invasiveness of the procedure and other things that come with testing during pregnancy. Some other options to consider are using an egg or a sperm donor or adoption. And I really want to highlight that each decision is highly personal and there are no right or wrong choices to make. So this slide, I won't go into much detail, but I just wanted to point out and show some of the things that people might consider when they're thinking about whether they would like to have genetic testing before or during or after a pregnancy. And one of those things is certainly the severity of the condition. We know that inherited bone marrow failure conditions can be very variable, some very severe and some less so that can have a very big impact on what choices you make. The cost of the possible procedures and so on, and also the impact on yourself and your family and those around you. And lastly, I just wanted to talk about the importance of cord blood storage if you do have a baby, because the umbilical cord contains blood-producing stem cells, and those stem cells can be stored and used for stem cell transplants at a later date. And so these cord blood samples are so precious to us because they may be very valuable if another child in the family or a sibling might need a stem cell transplant in the future. So certainly something to consider if you or a family member have an inherited bone marrow failure condition, whether you'd like to store the cord blood of your baby. So if you, your partner or a family member have an inherited bone marrow failure condition and are wondering about your family planning options or any of the things that I briefly touched on today, I really encourage you to get in touch with us via the email that's on your screen now. And we're always happy to answer questions. We're a specialised service, as Lucy has said, and I've spoken about. We specialise in bone marrow failure conditions. And we welcome patients from all over Australia, so you don't have to be local to us. We can do telehealth appointments, and you'll have access to a genetic counsellor and a specialised haematologist. And importantly, one thing I really want to stress is you do not have to want genetic testing to come and see us. Our role is to provide you with all the options and support you in whichever choice you make. Thank you very much.
Thank you very much, Laura. And please do put your questions in the chat or save them up for the end for Laura. So we'll move on now to Kari Peters. Welcome, Kari, who is a Comfort First clinician at the Children's Cancer Centre at the Royal Children's Hospital. And I'll let you share your slides, Kari, and get straight into it.
Thank you, Lucy. Sorry, I'll just get that.
Good evening. The Royal Children's Hospital is about to close for the night. Visiting hours end at 8 p.m.
Pardon me, sorry, there was an overhead announcement at the exact time I was starting. Thank you very much, Lucy, for the invitation to come and speak with you all tonight. I'm very pleased to join you all. So I'm going to shift a little bit towards a clinical perspective as far as how we can support children and young people with their medical procedures, and more poignantly, why preparation is important in doing so. So sorry, oops, there we go. So just as far as a definition of what we consider a medical procedure, and it's essentially a term used by health professionals to describe everything we do to children or patients to prevent, diagnose, or treat illness. And in our experience, what can be considered a simple procedure, like the removal of tape, can be highly distressing to children and young people. So it's very variant in people's experiences of medical procedures. When we consider procedural distress, the term distress refers to a combination of fear, anxiety, or pain. And procedural distress is often defined broadly as unpleasant physical sensations and negative psychological states associated with treatment procedures. It's our understanding that pain and distress response is individual and is learned, and it could be a result of undeveloped cognitive responses or an inability to understand the value of the procedure and why we're doing things that need to be done. That children or young people may have memories of or a prior experience that was negative. Those things, coupled with potentially a chaotic environment or inadequate treatment of pain and distress, or a child feeling a lack of control, can lead to fragmented or traumatic memories, which then could also lead to distorted and exaggerated memories. So why do we want to prepare children for procedures? So we understand that medical procedures can be stressful, especially for the first time, and children and young people may have unspoken fears or questions or misconceptions about what is to happen to them. So by preparing, we can reduce anxiety in what's to come, the unknown thoughts, the worries that exist when children are in their own thoughts and minds. We can develop trust in staff members and the carers themselves. We can develop coping strategies that are individualized, and we can give a sense of control. So when we think about preparation, we have some principles, and the first one being relationship building. So essentially getting to know each individual within their context, and that can be their likes and dislikes in the general world, but it also could be about how the child feels about the procedure today, some of their self-soothing techniques that they use and how we can incorporate those into the medical procedures. What procedure the child has previously had and how it went, and what has previously worked well or has been unhelpful. When we look at the environment, we can consider the noise in the room and the level. If children are highly sensitive to light, a lot of our kids, some of their treatment makes them quite photosensitive, so we're changing the lighting. Consider personal preferences and aesthetics. And then also what's visible to the child or young person in a treatment is really helpful to consider. Sometimes our treatment rooms have some very odd things that get propped in corners, so making sure things that are covered and put away neatly is really helpful to maintain a sense of calm. And then most importantly, I think, is about sharing a plan. So developing a plan with the child and family and the caregiver that everyone understands ahead of time, and it's communicated clearly. And when we consider procedures, we think about them in terms of before, middle, and after. And all of those opportunities have a chance for us to learn and grow and experience positive outcomes. So when we consider preparation for the child and the adolescent, I won't go through them all, but essentially it's about providing developmentally appropriate information. And it's not, I hope you notice that we're saying developmentally appropriate versus age appropriate, because I think young people have a tendency to regress when having medical treatments, especially in adolescence. We see regressive behavior in the face of pain. We want to give choices, but not absolute control to children. And we want to make sure we're giving choices that are attainable. With adolescents might minimize or deny their pain. So those are things that we really consider when we're supporting them as well. And we're also considering you as the caregiver, because we like to stress how it's quite impacting to hold your child when they're distressed. So considering how you may feel in a treatment is really important. And I like this picture because I think it's quite apt for how I think humans respond to stress. And it's not much different from our children. So what we see in children, we often see in ourselves as adults, but also in young people and in caregivers in these situations. So recognizing that procedures may trigger unexpected memories or feelings for the caregiver, and that the behavior of all the adults in a procedure can make a difference to whether a child copes or becomes distressed. So that's including nursing, ourselves if we're in the room, and all of us can impact that change. And finally, informed parents can take the lead of procedures and prevent the occurrence of escalation of distress in your children. So when we think about preparation and content, again, use developmentally appropriate language, consider step-by-step information, avoid high anxiety words like this is going to hurt like hell, and consider how much information to provide. And basically, if you're not sure what to say, really consider the senses. Providing preparation doesn't need to be a lengthy endeavor. It can be quite short and can be really concise, and that information is probably more helpful if it is smaller and contained. So if we consider things as, for example, if you're using a stethoscope, explaining to a child what it is, a stethoscope, and what they might feel. So you may feel cold on your skin. Where does it go? I'm going to put it on your chest and maybe on your back, and I'm going to ask you to take a deep breath. What's the purpose? We're here to listen to your heart and to your breathing. Just short, concise information. And finally, just to consider for everyone is what we look for as clinicians who support children in developing coping strategies. But what does a successful procedure look like? So for us, it's not necessarily did the child cry, it's more about was the procedure completed satisfactorily? Did they feel contained or out of control? Did it feel rushed or prolonged? Did everyone feel safe? Was distress minimal? Because children do cry with medical procedures. Did everyone understand their role? And how did the child or young person recover? And how will they feel about having another procedure coming up? Beautiful. That's a very quick run through of some support, but I'm very happy to answer some questions or have a chat with you if you want to get in touch.
Thank you so much, Kari. Please remember to enter your questions in the Q&A, and we'll certainly convey them to Kari and everyone else who has already spoken at the end of the evening. So we'll move on now to Jodie Bartle. Thank you, Jodie. Please do start sharing your slides. Jodie is a clinical specialist dietitian at the Royal Children's Hospital, and she's going to talk to us today about nutrition at home for bone marrow failure patients.
Sorry, I'll just do this. Oh, you're kidding. Sorry, it's just signed me out. I apologise. I'll just refresh.
Would you like me to share your slides, Jodie?
Yeah, I can't believe that I'm about to talk and I've had my slides up the whole time and it's just signed me out because I've been...
That's all right. I can do it if you like.
Yes, thanks. And I'll keep trying to sign back in.
Okay.
Thank you. And yes, so, yeah, thank you. Sorry about that. I can't, must be 1 hour in. Thank you for that introduction, and thank you to Maddie's Vision for asking me to come and speak tonight on the nutritional management of children with bone marrow failure. I've been asked to specifically focus tonight's session on graft versus host in the gut and Swatchman-Diamond syndrome. So I will talk a bit about how we manage those issues nutritionally. So next slide, thanks. So why is nutrition important? This is a bit of a generic introduction that I give to my talks because it's important to see what we're dealing with children who have bone marrow failure and often are undergoing transplants as part of their treatment. It's a crucial growing time. So it's not enough just to maintain weight in children. We actually need to keep them growing. And what we do know is that if a child doesn't gain weight adequately, we will also stunt their length. So it is a challenge to try and keep them growing in height and length. The treatments are often long-term and very intensive, and all of these have significant gastrointestinal related side effects. So most treatments come with nausea, vomiting, mucositis, which is ulceration from pretty much the mouth the whole way through the gut, which leads to quite severe diarrhea. On top of all that, we've also got frequent hospitalisation and family life disruptions. So it's not just that we're giving them treatment that's gut toxic, it's also that we're putting them, we're fasting them all the time, or there's the meals come at different times, just even getting in and out of hospital, all the waiting, family life disruptions, all these have huge impacts on common eating behaviours. So even if we could get in enough food, there's obviously a lot of other things going on as well. Thanks, next slide. So with graft versus host of the gut, this occurs in about 10 to 60% of our patients post bone marrow transplant, and it can vary from a stage 1, which can be just mild symptoms, through to stage 4, which has quite severe symptoms. Most often children present with severe diarrhea, but sometimes it can be in the upper gastrointestinal tract, so they'll present with vomiting and nausea and abdominal pain. Gastrointestinal recovery from graft versus host, once we treat it, can take weeks to months. So it is a very long process. It can be really frustrating for the families because the recovery can take so long. And occasionally it doesn't just affect the gut, it can also affect other gastrointestinal organs such as the liver and pancreas. Next slide, thanks. So the treatment of gastrointestinal graft versus host is with high-dose steroids. So this can have significant nutrition side effects. And the side effects we see from this treatment is an increased appetite. Steroids will have a huge impact on appetite. We also see a reduced lean body mass and an increase in fat mass. We see fluid and sodium retention. So often they can present with quite wasted legs and arms and a big belly in the cheeks. If they've been on steroids for quite a period, we can see steroid-induced diabetes. So they're not absorbing the sugar the way they should be. And that just adds another angle to how we manage the nutrition. Long-term steroids also can lead to bone demineralization. So we can see fractures and reduced length and height growth. And after a transplant where we do see graft versus host, we can actually see when they're on a long period of steroids, we can see a real flattening on the growth curve. But then once they finish their wean from the steroids, we often get that catch-up growth following weaning of the steroids. Next slide, thanks. So treating nutritionally, how do we treat gut graft versus host? Well, it's a really complex condition to treat because we've got a child that presents with severe diarrhea, and that could be, up to a couple of litres a day, 6 to 8 large loose bowel actions that may even be war. And so the first step to treating that is to start steroids and make them meal by mouth. However, when we start the steroids, we're actually making them really hungry. So this could be on the background of recovery from a transplant where parents are doing everything they can to get their child to eat. And then all of a sudden they find themselves in a situation where they're finally wanting to eat, they're starving from the steroids, but actually we're saying it's got to be nil by mouth because we require gut rest. So it can be really challenging to treat in those in the early stages. So children may be made nil by mouth, and we may require TPN, so total parenteral nutrition in through the central line, or even enteral nutrition. So in severe cases, it may be a grade over from parenteral nutrition onto enteral nutrition, and that's with the nasogastric tubes. So but then we've usually got that changeover period where we're giving them parenteral nutrition. We'd actually like to start, say, a continuous hydrolyzed or a pre-digested feed that's better tolerated, but because the child is so desperate to eat, usually we save any kind of food going into the gut for oral diet that can be eaten just for sheer to provide comfort for the child who is so desperate to eat. So that can also provide challenges, because what kind of food do we provide these children when their gut is still sick from the graft versus host, which I'm going to talk about in the next slide. And then we also see some micronutrients, so vitamin and mineral deficiencies, probably most commonly zinc, just from the gut trauma. So we often see low zinc and some low vitamin D. So how do we treat diet when a child is absolutely desperate to eat, but we need to minimize the impact on the gut? Well, we have to think of the gut. The gut has high surface area, little finger-like projections called the villi, and when they get when there's trauma to them or inflammation, we lose that ability we lose the enzymes in the tip of those villi. And so the enzymes that are there are mainly your carbohydrate digesting enzymes. So for that reason, we need to be very careful about carbohydrates in these diets. So we know that the diet needs to be low lactose. We also know that it needs to be low fiber. We limit fat only because we need to be able to provide the child with some kind of food, and some fat has been shown to be good for gut adaptation and health. So we allow some fat. We also want to make it low sugar. That can be quite an osmotic kind of concentrated and make the diarrhea worse. And we want to limit carbohydrates. So we don't want to remove them completely, because then there's not much food left, but we want to limit them. That leaves us with protein foods. So we really want to encourage protein foods, and we also want to encourage small frequent meals. So that means we're not stimulating the gut to move quickly and then leaving it empty for a few hours and then putting a big meal in. The best way to do it is to mimic a continuous feed. So tiny little bits every hour. The kind of foods that we may encourage with this kind of diet would be things like eggs, lactose-free milk drinks, maybe something like a ham and cheese sandwich, or just some plain meats and vegetables. We can also offer the children lactose-free oral supplement drinks. So this diet can be challenging, and the hope is that as the gut recovers, we can allow more and more foods into the diet. I'll just ask you to skip the next slide for the interest of time, and go to the next slide. So now I'm going to focus on Swatchman-Diamond syndrome, which is an autosomal recessive multisystem disorder. And it also includes, one of the organs is the gastrointestinal system. In this syndrome, we see children who are pancreatic insufficient. So the pancreas is required to secrete enzymes, and they don't secrete these enzymes. In this condition, we also see children with micronutrient deficiencies, especially zinc and the fat-soluble vitamins. We see growth failure, we can see osteopetrosis, and we can see feeding difficulties. So the next slide, thanks. So with Swatchman-Diamond syndrome, the pancreas secretes enzymes that are essential for digestion of our food. So with this syndrome, they cannot break food down, and without being able to break down food and digest food, it can't be absorbed. Malabsorption leads to abdominal pain, diarrhea, excessive wind, and steatorrhea, fatty stools. So if it's not treated with enzymes, or we don't replace the enzymes, then we see poor weight gain, growth, and development. And the foods that I'm going to talk about, the three main enzymes used in digestion. It's amylase, and that's used to break down carbohydrates, proteases that are used to break down proteins, and lipases, which are used to break down fats. Next slide, thanks. So in Swatchman-Diamond syndrome, we rely on pancreatic enzyme replacement therapy. So it's called PERT therapy. And these are capsules that are given they're enterically coated, and they contain the lipase, protease, and amylase, and they're designed to deliver enzymes into an active form into the duodenum, where they can digest the food. Next slide, thanks. So with PERT therapy, enzymes need to be distributed evenly throughout the day. So you can't go and give them all at one end of the day. They can be taken immediately before, during, or after meals and snacks. And as long as they're swallowed whole, the actual timing around the meal isn't important. When we dose children with Swatchman-Diamond syndromes with enzymes, we base it around lipase in there as an indicator per gram of fat. And there are upper limits of how much you can get. The Creon enzymes can come in 5,000, 10,000, 25,000, 40,000. So a breastfed baby may be on 5,000 Creon a day, whereas an adult would be moving up into the 40,000 international units per tablet per day. Next slide, thanks. How we manage diet in this situation is we estimate the fat content in the diet. So we have a look at what's the average intake at each meal and snacks, and then we aim for a minimum dose to control the symptoms to begin with, because we don't want to give too many enzymes. Doses are based on grams of fat, and they vary between individual patients. And so often a child may end up with 3 or 4 Creon for breakfast, 1 or 2 for lunch, 3 or 4 for, 1 or 2 for morning tea, and 3 or 4 for lunch, and so on. So depending on what their intake looks like, they have it's matched to the enzyme doses. Next slide, thanks. Sometimes in these children, nutrition isn't enough orally, so we need to rely on enteral nutrition, and this can be via the nasogastric tube or the PEG tube. But it does also prevent challenges about how we give this, what type of feed do we choose. So we can either opt for overnight feeds versus bolus feeds. Generally speaking, most families will choose an overnight feed so they can be free from the tube during the day, the tube feeds. So roughly we start at about 50% of requirements, and then we titrate that with the oral intake and weight and growth. Whether we use a polymeric or a semi-elemental. So a polymeric feed is like a whole protein. You might have heard of Nutrini or Osmolite or Nutrison. So our kind of standard feeds. But sometimes if we're not getting good growth on a standard feed, or we're getting poor symptom control, we may choose a semi-elemental feed, and that would be a pre-digested feed, such as things like Peptimen Junior, Vivinex and Neocate. You may have heard of some of those formulas. And we also rely on some oral diet with that. So the other thing is when we look at enzyme administration, it's ideal versus realistic. So in an ideal world, you'd be giving, if you're running a continuous feed, you may deliver enzymes every 2 hours through the night. However, that's not realistic. So what we'll often do is get the overnight feed, estimate the fat content, deliver the enzymes matched on that, and we'll give half of them at the beginning of the night and the other half at the end of the night. So next slide, thanks. And finally, we just need to think of some other considerations where there is a fat malabsorption. Often we also see vitamins, fat-soluble vitamins malabsorbed. So we need to be monitoring those at least yearly, and supplement with VitaBedec, which is a specialised fat-soluble vitamin replacement. We also need to look at growth failure, and we need to have a look at management of feeding difficulties. Thanks.
Thanks so much for that, Jodie. It's very interesting, obviously very important topic, I'm sure, one that worries a lot of parents if their child's not getting enough nutrition. So thank you very much. We'll move on to our next speaker. So I'd like to welcome Eloise Borrello. Eloise, please share your slides. Eloise is a clinical nurse consultant who specialises in vascular access at the Royal Children's Hospital here in Melbourne. Another topic dear to every parent's heart, so thank you.
Good evening, everyone. Thank you for having me. I'm delighted to be here tonight and sharing a few insights about caring for vascular access devices. So just a quick overview of this presentation. Firstly, we'll be going over what a central venous access device is, or a CVAD, and why we use them. We'll also cover some of the common complications, and by the end of the presentation, I'd also like to share some resources for you to take home with you. But before I begin, I always like to start with the sort of giving some historical context to the devices we use and looking back in time to sort of see where we are today. So vascular access devices were first recorded in the 16th century, where they used feather quills to gain access to the venous system. Luckily, we've come a long way since then. So in the 1970s, there was a paediatric nephrologist by the name of Dr. Hickman, who created the double lumen Hickman catheter. And this is the type of device which I'll be talking mostly about tonight. But it was really revolutionary for the time, and it really changed the way that we were able to provide care for patients undergoing bone marrow transplants specifically. But now we use these for a wide variety of conditions in both paediatric and adult, in the adult setting. And luckily in 2022, we've come even further, and we've got a whole range of dressings and securement products that we use to care for these devices. And I'd just like to share a little photo here of a patient who was treated at the RCH REL, who's very happy with how her Hickman catheter is dressed and secured, along with her little meerkat there, whose name is Mr. Simples. Before going on too much further, I just want to go over what a central venous access device is. So there's many different types of central lines, we call them. So there's lots of different names, central lines, but basically a central line is when the tip of the catheter sits in a position called the SVC. So if you look at the yellow arrow there, that's where we want the tip of the catheter to be sitting, or in the cavo-atrial junction. So there's lots of different types of devices. Some are called PICCs or ports or CVCs, but for many patients undergoing bone marrow transplants or hematological conditions, they'll require a cuffed device, which is what I'll talk about now. So we previously called these lines Hickman lines or Broviac lines, but it's not really describing the function of the device. So now we've changed our terminology to call them tunneled cuffed centrally inserted central catheter. So the centrally inserted central catheter part is the sort of basic name for all central lines that we use now. And then the tunneled cuffed part I'll explain in just a minute. All central lines are usually inserted into a vein in the neck. So that's where the orange arrow is pointing to. So we'd either call that the entry site or the insertion site. So the person will cannulate a vessel in the neck using a needle. And then for tunneled cuffed lines, the device is tunneled through the subcutaneous tissue underneath the skin. And then the catheter exits through the chest wall. So the purpose of tunneling the device is to actually prevent microbial entry through the entry site. So this portion of tunneling actually helps to prevent infection. And then the cuffed part of the device is actually to help prevent dislodgement. So the cuff is made out of a little piece of fabric, and what actually happens is the subcutaneous tissue adheres to that cuff, and that usually takes about 4 to 6 weeks post-insertion. So it doesn't happen straight away, we have to wait a little while. But that's how now we've come up with the term tunneled cuffed centrally inserted central catheter, which is a bit of a mouthful, but we try our best. So when we're caring for devices, or when I'm teaching anyone about a central line, I usually break it up into 3 portions: the insertion phase, the maintenance phase, and the removal phase. So insertion and removal is actually quite a quick procedure, but most catheters will spend their time in this maintenance phase. So what happens during maintenance is, well, we use the device, so we'll use it to give medications such as fluid and medicine and TPN, like Jodie has just mentioned. And something else that I didn't cover previously is the point of keeping a catheter in that SVC, in that really big vessel, is it allows for quick dilution of the medication that we're giving, and it prevents damage to the smaller vessels, which could be in the hand or arm. So it's in a position that's really quickly diluted, and it also allows us to take blood tests, and it also can stay there for a really long time, from weeks, months to years. So some patients will have their line in quite a lot for this maintenance. So that's when we're giving medication, that's when we're taking blood tests or giving blood transfusions. And it's also when we're caring for the device, so doing dressing changes or needleless connector changes. But whilst we do take a lot of care during maintenance, there can be some complications that we see. And the 3 most common are infection, blockage, and accidental removal. So I'm going to touch on each of those just briefly. So infection, there's a few types of infections. So sometimes there can be a local site infection where the line either enters or exits the skin. But the one we worry about most is bloodstream infection. And that's when bacteria can make its way from the external environment and into the vein and then into the bloodstream. So we sort of try and prevent infection at these 3 main points. So at the entry site, so we'll clean the skin using a product which has alcohol, which has instant kill the bacteria, because all of us are covered in naturally forming flora. And then another product called chlorhexidine, which has a residual antimicrobial effect. And some hospitals will use another dressing called a BioPatch, which has prolonged exposure to chlorhexidine. The other part of the catheter which can risk infection is the hub. So when nurses are accessing these devices, we scrub really hard to try and prevent, to break down any bacteria that could be sitting on the outside of the catheter. And then also the infusates or medication that we're giving. Something that's not mentioned here to help prevent infection is making sure that the person who has a central line in continues to bathe and shower every day, or attend to hygiene as best they can. So there's been really good studies to demonstrate that continuing to have a bath every day is a really important part of caring for any patient with a central line in situ to reduce that bioburden on the skin. The next type of complication we see is a blockage or an occlusion. So there's three main types of occlusion. And the first one is a precipitate, which I won't talk about. That's when two chemicals meet or two drugs meet in the line and cause a chemical reaction. A mechanical occlusion can occur when there's a kink either inside the device or on the external part of the catheter. So I have been known to go and try and access a line and the clamp's still on. So sometimes it's as simple as undoing a clamp, or it could be that there's been a kink in the device. But the most common one is a thrombotic occlusion, and there's 4 types of thrombotic occlusion. And the one I would want to draw your attention to is the second one from the top. So that's when there's been a little bit of, it's called an intraluminal occlusion, and there's a little bit of a blood clot sitting inside the line. And this is the most common occlusion we see, and it occurs in about 25% of catheters. So as we're taking so many blood tests and giving blood products, little bits of fibrin and blood can stick to the inside of the catheter. So this can be treated with a drug called alteplase or TPA or urokinase, and it just dwells inside the device, and then we can withdraw it and flush the line again. If that doesn't work, then we'll have to look at other causes of occlusion, but usually it is pretty successful in about 80 to 90% of cases. And then the third one, accidental removal. So this can be quite tricky in the paediatric population, because see 3-year-olds walking down our hallways and they've got all of their lines attached, and parents are trying to keep up with them as they're pushing their prams or they're in their trikes when they're walking around the hall or at home. But some things I just want you to walk away being aware of, and this is any patient population, is when the lines are connected to all the infusions going through the device, is the weigh chairs. When we review all lines that are accidentally removed, sometimes lines and things get caught in the weigh chair and it puts traction on the line. And if you think about that tip position, it pulls the line out and the tip is no longer sitting in the SVC. The bed rails and also some bath rails are notoriously difficult for keeping lines secure. When I was doing some research for this presentation, I was looking up some in the literature to see what's available for patients and families caring for devices, and there isn't a lot actually, but our Australian colleagues at the Avatar Group, and in particular Queensland Children's Hospital, have developed an app which, if you scan this QR code, it will take you to a website called the Avatar website, where it can where you can download that, give you instructions to download the app. But this I guess that the idea of this app is really to empower people with vascular access devices to keep a record of what devices you've had, where they've been inserted, who inserted them, what vein they've been inserted into, and also that also links you to some other information which may be helpful to you. So I'd encourage you to download the app if you do require a central line. But yeah, this is a great opportunity to engage with people who do have these devices, and we can help. You can teach us as well. We're very happy to learn from you. And just if you want some more written information, we've developed Kids Health Info fact sheets. So every device that we use in paediatrics is available on our Kids Health Info website. They're written for paediatric patients, but all the information is very applicable to adult patients as well. And thank you for the opportunity to present tonight. You can contact me with my email that's just shown here.
Thanks so much for that, Eloise. Such very, very, very precious devices that we all people in the hospital and patients and families need to know how to care for them. So thank you. We'll move on to our next speaker. So please remember to put questions in the chat if you have questions for Eloise. I'd like to welcome now Andrew Deans, Associate Professor Andrew Deans. Andrew, please share your slides. Thank you. Andrew has had several years now, many years of research in Fanconi anemia, and he leads the Genome Stability Unit at St Vincent's Institute here in Melbourne. So thanks, Andrew, very much.
Okay, thanks, Lucy. And thanks to MRV for the invitation to present at this forum tonight. I'm going to be giving an express introduction to some near future therapies for bone marrow failure syndromes. So to start with, I'm going to quickly touch on why we need an alternative to the current therapy of bone marrow transplant, which I also should stress is actually a very successful therapy. There have been thousands of patients treated via the transplant of bone marrow from a donor to a recipient over the last 40 years. But briefly, we all know it's really hard to find donors. For some patients, in fact, it can be impossible. And even once a donor is located, the whole process of transplantation is quite toxic to patients. It requires these toxic conditioning regimes to kill off the remaining bone marrow, which then, of course, goes on to suppress the immune system and means extensive hospital times required during transplantation. These transplants can also lead to consequences such as reduced fertility, higher number of cancers later on in life. And of course, the big one, there's a possibility of immediate or delayed graft versus host disease. And this is a thoroughly terrible disease that actually killed a very good friend of mine about a year after his transplant and made me very passionate about trying to find alternative treatments for bone marrow failure treatment. So gene therapy and gene editing should really help to overcome all of these problems, because the donor would in fact be the patient themselves, and no conditioning is required, no immunosuppression, and the worst consequence, of course, is graft versus host disease should be gone. To do this requires the isolation of the patient's own stem cells and modifying them outside of the body. And so for clarity, I need to just start by defining stem cells. Of course, we can go all the way back to the beginning. Humans start out as a single cell from the fusion of a sperm and an egg, and this cell then goes on to divide and becomes embryonic stem cells. And if you think about it, these embryonic stem cells have the capacity to make an entire human. They can go on to form every cell in our body. And so these are really the ultimate stem cell. They can become anything, but they're not what we're interested in here. And as embryos develop over the first few weeks, the embryonic stem cells start to become more specialized. And as tissue and organs start to form, even more specialized stem cells arrive. And you can see that there's many different stem cells that can go on to form different things such as the heart, the skin, the gut, and of course the blood. Now, blood stem cells are called hematopoietic stem cells or HSCs. And then these further differentiate to all of these different cell types that are found in the blood. And you can see that this whole process looks a lot like a tree. And the hematopoietic stem cells on this branch, if we were to cut out this branch, they would then be able to go on and regenerate this part of the tree, but they can't regenerate other organs. And that's because they're specialized, they're differentiated to only be able to produce blood. So they can go on and make all the different kinds of blood cells. So these include the red blood cells, platelets, and all of the immune stem cells. And in most forms of bone marrow failure, it's actually these hematopoietic stem cells that are the problem. They're what are failing. In an acquired bone marrow failure settings, it's often the immune system that's attacking these cells unexpectedly. But in inherited bone marrow failure, which is what the interest of my lab has been for a long time, it's really an intrinsic problem of these cells to be able to grow and to make more blood. And while on the normal, in the blue line here, normal individuals have enough of these hematopoietic stem cells across their lives to be able to produce all of these different blood cells, right until they're, maybe 100 years old. But in patients who inherit some of these defects, that number of these stem cells rapidly progresses towards zero. And in these patients, this is the point at which bone marrow failure would be occurring in perhaps in childhood or early adulthood. So this capacity to continue making hematopoietic stem cells throughout the life is actually controlled, of course, by DNA as kind of the majority of how we work is controlled. So the second topic that I have to briefly introduce is DNA and genes and genomes and chromosomes, which we've already heard a little bit about today. But I'll just give you another analogy, and I want you to think about DNA literally like an instruction manual for controlling this tree and this differentiation program that makes all these beautiful cells that kind of makes us who we are. So unlike English, it's written just in 4 letters. And of course, the way that it's read is very different to how we read. But for simplicity, one gene is one instruction. So the instruction for one protein to be made. Now, these genes are found on chromosomes. And so a chromosome can be thought of as a set of instructions, and humans have 23. volumes. And then this full set of these volumes together is what's known as a genome. So, you know, if you or your loved ones have their whole genome sequenced, what we're doing is looking at and reading all of these genetic instructions. And through decades of research, we have a reasonable understanding about the function of what some or many of these instructions do, and why, when they're absent, it can lead to the formation of, it can cause bone marrow failure syndromes. So scientists give kind of funny names to these genes based on what we think they do. And this is a short graphic of some of those that are that can cause bone marrow failure. But importantly, these genes cause bone marrow failure when they're not working. So, for example, in Fanconi anemia, which is what I'm mostly interested in, caused by a FANK mutation, this FANK gene has a mistake in it, in the code, and it means that the instruction is either completely lost or it's jargon. So to show this literally, here are some sequences of the FANK gene. It's made up of the 4-letter code that provides a very specific instruction for making the FANK protein. But in this version of the gene down here from a patient with Fanconi anemia, just one letter is deleted and it leads to a shift in all of the downstream letters. Now, kind of to a non-scientist, and it kind of, it looks like this is, you know, one letter missing, so what? So I'm going to give you an analogy and instead imagine that this instruction manual was for making party cakes. Now, we all like to bake. This is a pretty simple recipe. But you can see that it's completely readable. And if I was to follow this instruction, I'd be able to make a pretty basic cake. But if I was to make a similar mutation in this recipe, in the mutant recipe, you can see now that we've removed one letter. All of the other letters have shifted one letter over. And really this recipe's become unreadable and I wouldn't know how to finish making this cake. In a different mutant version of FANK, maybe a large piece of the gene is actually missing, but the actual, and so again, by analogy, we would have something that was readable, but it's missing crucial information. And so again, for those of you who bake, this recipe would be a disaster. And for FANK patients, it's also a disaster because they can't make functional hematopoietic stem cells when they've got one of these mutations present. So I hope you will be able to appreciate now from these analogies about how we could then go on and use gene therapy and gene editing to kind of fix these mistakes. So gene therapy and gene editing, you might have heard, they're actually fundamentally different from each other. And they're both technologies that are quite different stages of development. So gene therapy is actually already in clinical trial. And here's how it works. Okay, so first we isolate stem cells from the patients in the same way that we would if we were going to be taking cells for an unrelated donor transplant. But outside of the body, the cells from this patient are then infected with a virus that can carry, this is a non-infectious virus, this is a virus that will carry with it a copy of the normal FANK gene or the FANK instruction, and it will insert it into the DNA of the stem cells of the patient. These cells are then transplanted back into the patient. And again, this doesn't require conditioning, it doesn't require toxic therapies because you're basically putting this person's cells straight back in a few days later. And actually, remarkably, this works really, really well. So in this 2019 paper from the journal Nature Medicine, they showed that 4 children who participated in this clinical trial had successful engraftment of cells which had been corrected with this type of viral gene therapy. And so you can see, for example, in this patient, the FANK positive cells expanded rapidly within their blood. And if we look specifically at leukocytes, you can really see how the cells which receive the gene therapy have grown rapidly to replenish the bone marrow of the children, even while the original cells shown in red continue to decline in number over the months after the transplant. So this was, look, a really exciting piece of evidence for the field that we now have a potential to actually stop this bone marrow failure from even happening in the first place in some of these children. So in the last minute or two, I just wanted to talk about gene editing because gene editing is going to be the next thing, and it's not yet in clinical trial, but I think it's proving really exciting in its possibilities. And we're moving more towards gene editing because although gene therapy is exciting, of course, virus delivery has some types of risks. It's also incredibly expensive, and it requires a separate trial for every gene that needs to be corrected. And so we know in bone marrow failure, there's lots of different genes. FANK was chosen because it's the most commonly causative gene in Fanconi anemia, but other genes are not currently being trialled. It also requires a lot of cells. So with gene editing, instead of using a virus to actually bring in an additional copy of the method or the recipe or the gene, we actually use non-viral methods to get inside the cell. And in this way, we can actually rewrite the genetic code directly. And there's a lot of tools that are out there now, really exciting tools. And these use programmable instructions tailored to the specific mutation of the patient, because we know that most bone marrow failure patients have different causative mutations. They don't all have the same. And we can rewrite the genetic code to become a normal sequence. And I'm apologizing that I'm still using the recipe here. It's just a nice analogy that helps to make it very clear. Gene editing is kind of in its infancy compared to gene therapy, but I really think it's going to supersede it. And I wanted to show you just quickly at the end some exciting results from Lu Liu, who's a PhD student in my lab. And she's actually spent the past 2 years trying to advance the use of gene editing in primary hematopoietic stem cells. These are mouse hematopoietic stem cells. I won't give you the specifics of the assay because I'm going to be talking about it in next week's specific session on Fanconi anemia. But from this assay, she's been getting, just recently, got some really exciting results where we're getting over 50% of the cells have been edited. And Astrid Glasser in the lab has also got some really exciting results showing that we can edit Fanconi anemia mutations as well. So these type of results mean that gene editing could in fact be closer to reality than we actually realized, because it just seems to be so exciting in how rapidly and how well it works without any side effects that we're aware of. So in summary, both gene therapy and gene editing are hopefully going to revolutionise the treatment of bone marrow failure. It's going to require a lot of investment and a lot of upskilling and new kind of centres, but they're coming online in Australia for both for other types of genetic diseases. So we're going to be able to make it happen. I'd just like to finally point you towards a trial that you can enrol in that will help us and other researchers develop gene therapy and technologies for bone marrow failure research. Please check out the FASA website, or you can contact me by email. I'm always enthusiastic and excited to talk about this work. Thanks very much.
Thanks so much, Andrew. It's a very exciting topic, and we look forward to hearing more about it in your Fanconi anemia session and perhaps later tonight in the Q&A session. We'll move on now to our last speaker. So can I please welcome Dr. Rebecca Walsh. Rebecca, please share your slides with us. Rebecca is a laboratory and clinical haematologist and clinical genomicist. She works in the Randwick Genetic Laboratory of New South Wales Health Pathology, and we're grateful to have her speaking about acquired mutations. So thanks so much, Rebecca.
So thanks, Lucy, and also thanks to Lucy and Andrew for some great explanations that are going to be relevant for this topic. So there's a lot of talk in the medical literature about acquired mutations in both health and disease at the moment, and the bone marrow failure syndromes are no exception. And I think this is fantastic because it's contributing to our knowledge that the bone marrow is very complex and dynamic, and that the more we understand these processes, the better we can personalise treatment and improve the outcomes for our patients. So I'll start briefly with just some basic genetic concepts, which Andrew beautifully explained, but we'll just go over them again because it will help explaining the complexities of the acquired mutations. So all the cells in our body have DNA, and this is a very complex molecule that contains all of the genetic information necessary to build and maintain an organism, including us. And chromosomes are these thread-like structures, which you can see here. And in which DNA is tightly packed within the nucleus of a cell. And a mutation is a genetic change that has the potential to cause disease. And this can occur at any point from the building blocks of the DNA, which are called the nucleotides, to the genes, and also including chromosomes. So you can gain or lose whole chromosomes, or the chromosomes can be rearranged. And so the other important concept is germline versus acquired mutations. And so what's the difference between acquired, which we also call somatic mutations, and germline mutations? So a germline mutation is a genetic change in the body's reproductive cells, so the egg or sperm, and that becomes incorporated into the DNA of every cell in the body of the offspring. Germline mutations are passed on from parents to offspring, and as Lucy spoke about earlier on, that they are the underlying cause of the inherited bone marrow failure syndromes. Now, somatic or acquired mutations is a genetic change that occurs after conception to any cell that isn't a reproductive cell. So they don't pass from parent to children, so they're not inherited, and they're often associated with cancer. And of note, it's possible and in fact probable in bone marrow failure patients to have both germline and somatic or acquired mutations. And so why are mutations acquired in the bone marrow? So in bone marrow failure, there is a pre-existing molecular or cellular defect in the stem cell, and that results in exhaustion at baseline, and consequently the marrow's ability to produce cells that circulate in the blood that are critical to life, which I think Lisa touched on earlier. But we've got the stem cells here, and they are responsible for producing the red blood cells, which are the oxygen carrying cells of the body, the white blood cells, which are important for fighting infection, and the platelets, which stop us bleeding to death. And so acquired mutations can compensate the underlying defects, and this confers a growth advantage. And so we call this the Darwinian effect, because it's a concept where it's survival of the fittest stem cell. And acquired mutations in bone marrow failure have two very contrasting mechanisms. One is a rescue mechanism, and one results in malignant transformation. And keeping in mind that one of the hallmarks of bone marrow failure syndromes is that there is a risk of transformation to the malignant hematological conditions of dysplasia or AML. And so just looking at that concept again, this is the process of rescue, where the hematopoietic stem cell, which are these represented here, and already these cells are not functioning properly due to a germline mutation or an immune attack, and these cells acquire another mutation that reverts the cell back to a so-called normal function, and in a way it's fixing the underlying mutation, and this means that these cells have an advantage, not unlike the survival of the fittest concept. The other situation is in a way quite the opposite, where the stem cells acquire a mutation that's called a high-risk mutation, and it's high risk because it means that those cells are very highly predisposed to transforming to myelodysplastic syndrome or AML. And the other thing is that this situation is very good for patients. Often they'll be stable with good full blood counts, and maybe obviously this situation is not good in that patients may develop malignancies. There is a whole lot of mutations that are sort of in the grey zone that sit here though. And so we're gathering more and more evidence in regards to the types and nature of acquired mutations in bone marrow failure syndromes. And generally, each different subcategory of bone marrow failure has distinct somatic changes. And I think this table just briefly summarises some of that information. So if you look at aplastic anemia, about 50% of patients have a change in chromosome 6, which is called uniparental disomy, or they have a mutation in the PIGA gene. In Shwachman-Diamond syndrome, about 72% of patients you can detect acquired mutations, whereas as you move down the table, only about 10% of patients with Diamond-Blackfan anemia will have acquired mutations. And one of the recurring themes is that the high risk changes are very similar. So if you lose chromosome 7 or part of chromosome 7, you are at a high risk of developing AML or MDS. And one of the molecular abnormalities that are high risk is TP53. And so this is just a very brief case study because I think it always helps illustrate some of these concepts. So we've got a 9-year-old boy who is a compound heterozygote for the BRCA2 gene mutation, resulting in Fanconi anemia. And so he has multiple congenital anomalies, and they're all in keeping with the Fanconi anemia syndrome. So he has hearing loss, he has a PDA, hyperspadias, he has cafe au lait, macules, which are changes to the skin, growth hormone deficiency, and a right frontal lobe lesion, which has been stable for many years. So his blood counts have always been normal, but he has been undergoing bone marrow analysis every 6 months, which is not an uncommon thing in the bone marrow failure patients. And so this is a summary of his bone marrow analysis. I think the first thing to notice actually is one of the results of COVID is that there's quite a big gap in his surveillance. And the cytogenetics, which is in this column here, shows the acquired chromosomal mutations. And at first glance, this looks a bit messy and very complex. But actually, this represents a very low level. So there's 1 to 3 cells in at least 20 that have been counted, and quite stable changes. So there's a rearrangement or translocation between chromosome 10 and 11, and a translocation between 8 and 9. And that they're sort of picked up most times he's had a bone marrow, and there has been a deletion of part of chromosome 7, which always makes people nervous because it's called a high risk mutation. But in this patient, it's at very low level, and actually in subsequent marrows, it has disappeared. So the point about this is that these results are very reassuring, and they actually match the stability of the marrow appearance, which is what you look at down the microscope, in that he has reduced cellularity in his marrow, but there's no dysplasia, and also his normal full blood count. And so the patient will continue to be monitored, and a bone marrow transplant is not actually a consideration at this stage. And so what does all this mean? So how can the knowledge of acquired mutations in bone marrow failure translate into better clinical practice and improved outcome in patients? So with surveillance, looking at these acquired mutations might mean that the frequency that we can tailor the frequency of surveillance based on the risk of malignant transformation. So if there's no high risk changes like we saw in the patient that I've just described, they might need to have a bone marrow biopsy less frequency. And it's possible that we may be able to do away with bone marrow biopsies completely and monitor just using a blood test. Andrew described very nicely the issues with bone marrow, with a bone marrow transplant. It is really the only curative treatment for for the cytopenias and the risk to malignancy. But there are a lot of risks associated with that. So the acquired mutations might help to predict in which patients and at what time leukemic transformation may occur. And then finally, the therapeutic invention. So Andrew has spoke about gene editing, but one of the things that's a common theme in hematological malignancies is the ability to target the mutation with the drug. And we see that in something like chronic myeloid leukemia, where the tyrosine kinase inhibitors that target the BCR-ABL mutation have been incredibly successful, and of more recent times in AML, the FLT3 inhibitors that target FLT3 mutations. Hopefully all the work that is being done on the acquired mutations in bone marrow failure will translate to meaningful changes to patient care. And with that, I'll hand back over to Lucy.
Thanks so much for that, Rebecca. Very complex topic and really nicely delivered, so thank you. I'd like to now invite all our panelists back to our Q&A session. I'm mindful of the time. We'll try and answer as many questions as we can. I'd like to acknowledge Servier, the sponsor of this Q&A session. And I'd also like to invite Mei-Ling Yeh, our telehealth nurse, to join the group as well. And in fact, while everyone's turning on their cameras and we're getting into gallery view, I might actually direct the first question to Mei-Ling. We've had, I think, a really interesting question. I think this is a really important one for patients with bone marrow failure who don't have a cancer, but they get care in an oncology clinic, which is quite confronting, and people may feel that they're the odd one out. And Mei-Ling, are you able to talk to us about the support services that are in place, potentially in the adult and the paediatric setting?
Yes, of course. Thank you, Lucy, and thank you for the questions. It is a really valid question, and it is the fact what our patient and family experience at this point of time. Most of our patients doesn't have a designated place purely because of the numbers, and it is fall into the rare disease category. So most of our patients and families, they will stay in oncology settings, and it's very, very common for our patients and families doesn't receive exactly the same support, even though we are receiving the same treatment and the care in hospital. So that's a really, really disappointed perspective. However, that is the time for us telehealth, Medis Vision telehealth support service get into. We are here to provide the service to the patient and the family, and we try to deliver up-to-date information, support the patient and the family through this journey step by step. So I really welcome these patients or family coming to us and give us a call, and I will guide you through the steps and also triage the resources which is needed. Thank you.
Sorry, thank you, Mei-Ling. I'm going to take a couple of questions from Karen, who always has really fabulous questions, and I'll direct them to you, Jodie, because I think they're best answered by a dietitian. There's questions about the types of feeding that are good for SDA patients, the particular type of enteral feeds. Can you answer that, please? You're on mute, Jodie.
Thanks, Karen, for those questions. It's a really common question about what formula do we use. Most of the time we're guided by symptoms of the patient and how they're growing. And if we look at our major groups of formula, we've got our whole protein, kind of more like a normal diet kind of feed, such as Nutrinis, Nutrisons. Note that they're also lactose free, so they are a little bit gut friendly, but they're a whole protein. Our middle group are our partially hydrolyzed feeds or a semi-elemental feed, and they're kind of where the protein's gone from a whole protein to a peptide chain. And they're also known as like pre-digested feeds. So they come with a mix of fat as well, and that will be like your Pepti Junior and Peptamen Junior and formulas like that. Then you move down further. So you've got the protein chain that's broken down to peptides. It's then broken to down to free amino acids, which are also known in your elemental formula, the free amino acid formula, things like Neocate and Alicare. We're always trying to keep our patients on as whole a protein formula as possible, dependent on gut symptoms and growth. And the reason for that is the larger the protein chain, the more normal the formula, the better the gut adaptation and recovery. But if the gut is not coping with that formula, then we need to move further towards the free amino acid formulas. Karen also had a question about why wouldn't we use free amino acids for SDS patients in transplants? A really good question, or graft versus host. A lot of the diarrhea that we see in transplant, and especially with graft versus host, there's a lot of an osmotic load to it. So like the formula is quite concentrated, so it pulls water in and can make the diarrhea worse. So that is the free amino acid formulas that are much higher osmolality than your peptide chains. So we would always choose as first line of choice in a patient with diarrhea our peptide chains. So some children do require free amino acid formulas, but we wouldn't routinely use them because of their higher osmolality in those patients. So yeah, it really depends on the symptoms of the child.
Great, thank you. Thanks so much, Jodie. Yvonne, I'm going to direct a question to you now. So again, another really important question about that transition from paediatric to adult care, about how we do that in patients with intellectual disabilities. What considerations do we have for them?
Yeah, thanks very much for that question. It's a really important one, and one that we are considering more and more. And look, we're really conscious in the adult sector that we can't always replicate the support services available in the paediatric sector as well. Fortunately, many of our paediatric colleagues who provide support to paediatric or adolescent and young adults transitioning to adult services will continue to see them for those support services. But in preparation for transition, what we do is we speak to have a number of conversations with the patient's main carer in order to establish a good rapport with them, but also to try and understand how we can optimize the experience for the patient at their first and then subsequent long-term follow-up reviews. So it does require more preparation in an intentional way, but it certainly doesn't take any longer. It just means that we have to make sure that we either continue with the support services that are being offered within the paediatric sector, or often we will get advice from paediatric specialists on who to refer patients to in the adult sector to ensure the transition is smooth, and then they can come to us and see us in the long-term follow-up service, and we do our consultation and then create a survivorship care plan for them like we would for all of our patients. But we may have a little bit of a hybrid approach in terms of what support services we have, utilising both people from the adult sector and the paediatric sector.
Thank you. So it's a huge task getting these complicated patients from one institution to another, a really challenging time of life, and guys do a great job. So I'll leave that question there. And what I might do is ask Laura, because I know Laura deals with this question quite a bit. If a child inherits a bone marrow condition, does it present in exactly the same way and at the same age as their parent?
Yeah, it's a good question. And I think, as has been beautifully shown by everyone's talks today, it's a very, genetics is a very complicated thing, and so is inherited bone marrow failure. And so the short answer is it really depends on the condition. We know that some conditions can get worse with each subsequent generation. We know that some conditions present completely differently between two siblings or a parent and a child who have the exact same genetic change, and you would potentially expect that they're all the same, but they're not. They might have different symptoms, they might have different onsets. So I think the short answer is it's extremely variable. We know that some things are very predictable and some are not. So if you're interested in your particular condition, I'd recommend you come and speak to a genetic counsellor or your haematologist who has experience in these things, and they'll be able to tell you more for your own, your own condition.
Brilliant, thank you. Andrew Deans, I'm going to flip it to you now. There's a couple of questions here that are related to your talk. Is it an easy answer? Is gene editing permanent once you achieve success in it?
Yes, definitely. So I realized when I saw that question, I had actually forgot to mention that one of the beauties of both gene therapy and gene editing is that it is a permanent change, a permanent correction that you're making to the cells. And there shouldn't need to be ongoing treatment, especially if it's happened in the stem cells.
Fabulous, thank you. And look, I think Karen asked another great question, and I think that this is not an easy answer. But in a world where we cannot offer these treatments, Andrew, to patients with Fanconi or other diseases, which is coming, we hope, soon. Do we have any idea about when the collection has to happen? Does it has to happen in the first year of life, or can it happen if they're 18?
So Karen has raised an important point, and in fact the Spanish gene therapy trial that I mentioned was conducted mostly in children, actually entirely in children between 4 and 12 years of age. I think more recently they've also had an 18-year-old patient, but it's exactly for that reason. So you need to actually perform the correction prior to all the stem cells actually being lost from the patient. And so it's a barrier for treatment of adult patients or older patients, people who present at the time of bone marrow failure. We can't offer this necessarily as a treatment. However, there's opportunities then for other alternative developing therapies, things that are in the pipeline, which is actually being able to generate these type of stem cells from other types of cells. And this is another really exciting area of research that has been touched on at previous forums, where you can generate stem cells from skin cells or from hair follicles or from other cell types, which haven't been under this kind of selective pressure that Rebecca talked about. Which is another problem. If you're working with cells that have already accumulated a lot of mutations, do you want to be actually giving those cells an advantage when you put them back into the patient and maybe promoting cancer? So it's complicated. We want probably as young as possible at the moment.
Great, thank you. Professor Ritchie, is your microphone on? I might direct a question to you because you haven't spoken in a couple of hours. So there's a question, and I think it's from Linda there, asking about novel therapies, I guess, I think in immunoplastic anemia. Have we got things beyond ATG and cyclosporin in immunoplastic anemia now? And do you know of anything that's coming? You're muted, David.
Not anymore. So Yeah, look, it's kind of interesting, isn't it? So the discovery of immunosuppression for the treatment of acquired aplastic anemia, although some degrees of immunosuppression might be useful in other forms of bone marrow failure syndrome as well, was essentially made by accident. People felt that aplastic anemia had the hallmarks of an overactive immune system attacking an organ, the same as might occur in forms of other conditions or diseases where the immune system has forgotten to ignore bits of the body and attack them, and that occurs in a range of commonly known conditions, autoimmune conditions such as rheumatoid arthritis or systemic lupus erythematosus or thyroiditis or various different types of thyroid disorder or other autoimmune conditions, even like diabetes. Type 1 diabetes is an autoimmune condition affecting the insulin-making cells of the pancreas, but there's a whole raft of other ones affecting pretty much any organ you can think of. And so this looked like a condition that was driven by the immune system and causing attack on another organ such as the bone marrow, and ultimately exhausting the number of cells that were able to make blood cells. And the patients presented just as that very first, or almost first slide that Lucy showed, which was an empty bone marrow, no evidence of red blood cell, neutrophil making cell or platelet making cells in the bone marrow, and a few ragtag leftover immune system cells, which seem to be the only thing surviving. And so from that observation was sprung this sort of almost almost biblical faith in suppressing the immune system to allow the bone marrow to recover. And so the most potent therapies that were around to suppress the immune system was this thing called ATG, or anti-thymocyte globulin. Thymocytes is another word for T cells, which are the main driver of the immune system, along with a drug that was commonly used in bone marrow transplantation and in other transplantation medicine, because it's such a good immune suppressor and prevents graft versus host disease, called cyclosporin, which basically is a sleeping tablet for T cells. It puts them to sleep. And alone, they do suppress the immune system, and for some people, as single therapies, allow the immune system to be suppressed enough for the bone marrow to wake up and start growing red cells and platelets and neutrophils. But together, they're the most potent immune suppression that we know, and sometimes that combination of immune suppression is called that. It's called potent immune suppression. Or now that in a sense has been the building block on which the new therapies of aplastic anemia have been compared or attempted to be enhanced. And but profound immune suppression with cyclosporin and ATG remains a cornerstone of treatment. And as you might guess, suppressing the immune system has other effects, such as risk of opportunistic infection. Opportunistic infections are infections that are generated by bugs that most of us can ignore because they don't actually make us sick, even though we're exposed to them. People who've got no immune system, bugs that ordinarily don't cause illness start to cause illness, like weird bacteria, weird fungi, weird viruses. And people with profound immune suppression are at risk of those developments. Nonetheless, we know that this is the single most effective way of allowing the bone marrow to recover the combination of ATG and cyclosporin. So that's our foundation therapy, if you like. So and based on that, there's been really an incredible amount of understanding of the role of the immune system in aplastic anemia, and what happens to the bone marrow when it starts to grow again after that immune suppression has been taken away. And a lot of the really interesting things is that it's actually underpins some of the chromosomal changes and molecular changes that Rebecca has talked about, and this idea that the bone marrow is not made up of a uniform population of stem cells that can all do exactly the same job, but there is a spectrum of stem cells, individual clones, or there's a degree of clonality to the bone marrow. And under some circumstances, when people actually recover from their aplastic anemia, the bone marrow has fewer choices with respect to the number of stem cells that it can make, because it's lost stem cells along the way. And those cells, when they're restricted in number, are at risk of making more mistakes that Rebecca's mentioned, particularly chromosomal and molecular mistakes. So people felt, well, look, there's possibly a better job to be done here. And of course, the mover and shaker in this field is a guy called Neil Young, not the singer, but the scientist, the clinician scientist out of Bethesda in Maryland, the United States, who's written very many excellent clinical trials and written on his experiences with understanding the biology of immune suppression. One of the things that is interesting is that ATG, as we know and love it, and is most commonly used in aplastic anemia in Australia and many countries, is derived from horses. I won't go into the reason why that is, but it is. And its competitor is derived from rabbits. So sometimes we talk about horse ATG, and other times we talk about rabbit ATG. And there was a very important randomized clinical trial done some years ago now, comparing the two in combination with cyclosporin. And for reasons that are unclear, the horse ATG won. Rabbit ATG was not felt to be as effective. In fact, it was considerably less effective. So
when was the last time you gave rabbit, David?
When was the last time I what?
Gave rabbit ATG.
To somebody with aplastic anemia?
Yeah.
Probably about 3 or 4 years ago.
Yeah.
Not as a frontline, but as an alternative when the horse ATG hasn't done its job.
Yeah.
We use rabbit ATG all the time for those people who are playing along at home in the prevention of graft versus host disease. So it's a absolute menagerie at the Royal Melbourne Hospital. We've got rabbits and horses and all sorts of things going on. But anyway, it's a rather long-winded response to a relatively straightforward question, but really building to a crescendo here, which is basically saying intensive immunosuppression was really, really important development and consolidated by those randomized trials. There were some other trials done along the way looking for the doses of ATG, and that's all been very well studied and established. But of course, and this came out of a lot of work that Neil did and co-investigators, which said, well, look, the immune system is only half of the equation here. The immune system is probably the driving force by the onset of aplastic anemia, but the recovery of aplastic anemia probably also needs stimulation of those blood-making stem cells within the bone marrow. And one of the most important types of cells that people often get into mischief with when they don't have enough of them and is hard to support on an ongoing basis is platelets. Now, platelets are made by a cell in the bone marrow called a megakaryocyte, which is just a fancy term for a big cell with a large nucleus. And it's a platelet making factory, and it's stimulated by a hormone called thrombopoietin, or TPO. And so people say, well, wouldn't it be great if we could get the platelets to be made a bit more as people are recovering from their aplastic anemia? And it just so happens that we've got this drug called, two drugs that mimic the effect of thrombopoietin. And one of those drugs is called L-Trombopag. Who makes up these names? I've got no idea, but somebody made up that name, L-Trombopag. And shall we add that to the mix, so that when we're actually trying to get people better from aplastic anemia, we've got the immune side of the equation, but we've also got, at the very least, this platelet driving side of the equation as well, to try and enhance the bone marrow recovery. And that was done in a clinical trial, also published in the New England Journal of Medicine. And lo and behold, not only did the platelets get better, but the whole bone marrow got better. People's red blood cells got better, people's neutrophils got better in higher numbers, and a greater proportion of people got better with that 3-drug mix. Cyclosporin, ATG, you couldn't get rid of it, but this L-Trombopag stuff seemed to be add that extra magical sort of ingredient that enhanced bone marrow recovery. So now you might say, well, if it's that great, how come it's not on the PBS yet? And you might very well ask that question, because we think it should be. And in fact, MRV have written in support to the Haematology Society of Australia and New Zealand, who have made a submission to the government to try and get L-Trombopag listed, so it's freely available, because it's currently not available to people with aplastic anemia on the PBS. But thankfully, to people like Lucy, Steve Ting, Erica Wood, and other co-investigators, they've launched a clinical trial, which MRV has been involved in to a certain degree, but largely off the sweat of those people's brows that I've just mentioned. There's a clinical trial called the DIAMOND study. And one of the A's in the DIAMOND study stands for a drug called avatrombopag. And for anyone who hasn't gone to sleep yet, you'll notice that avatrombopag sounds a lot like L-Trombopag, and it's a closely related drug. And that's available for people on clinical trial in Australia in combination with cyclosporin and ATG. And we hope, and it appears that trial is doing extremely well, incredibly well, and super importantly, has lots of samples being taken of blood and bone marrow along the way. And it's that element that MRV have contributed to considerably to try and understand the biology. Who benefits most from avatrombopag? Do we need to use cyclosporin? What are the relative what's the relative consequences of clonal expansion? How does the immune system recover after being suppressed? All of those questions can be answered by those samples. So, there are other drugs coming down the pipeline. Now, I'm just about to finish. Lucy, you'll be breathing a sigh of relief about this. So one of the things that the TPO mimetics, such as avatrombopag or L-Trombopag, really highlighted is that platelet-making cells, megakaryocytes, are important for bone marrow health above and beyond actually just making platelets. They seem to have a supportive role in the bone marrow for stem cells and for their stem cells' ability to make red blood cells, white blood cells, and platelets. And that's turned attention to other drugs that might actually enhance that microenvironment that stem cells live in. We know that aplastic anemia is a very inflammatory environment for stem cells to grow in, and there's been some work about trying to dampen down that inflammatory response. There are other drugs that enhance that stem cell niche that we imagine will be added to the treatment of aplastic anemia. As far as drugs that suppress the immune system, though, I think we've probably got the right combo with the cyclosporin and ATG. So I'll stop there, Lucy. Thanks.
Great, thank you. I think the drugs that you mentioned at the end, the L-Trombopag and the avatrombopag, I think one of the things you mentioned was, in addition to helping the platelets, it can help some of the other blood cells as well. And I guess what an interesting question then is, well, if we can use it in immunoplastic anemia, well, could you use it in other bone marrow failure diseases? And we have concerns about that bone marrow stimulating agent. You know, is that safe in a patient with a condition such as Diamond-Blackfan anemia or another inherited bone marrow failure condition? And I've seen at the upcoming American Society conference that's coming up in December in the States, there is a group presenting on the use of L-Trombopag in Diamond-Blackfan anemia. And so that will be very interesting to hear if they had any success with that, or any safety concerns, and if there's any valuable information from that kind of presentation, we would certainly aim to inform our patient and family communities at another one of these events down the track. I'm mindful of the time. We're a little bit over time, so I might wrap it up there. I know we haven't got through all the questions, but I think you've all been very attentive for nearly 2.5 hours. So I would like to finish. I want to thank our sponsors, Alexion, Servier, the Victorian State Government. I want to thank my colleagues on the subcommittee, Paddy Barbaro, Tracy Bryan, Adam Nelson, Belinda Go, Parvathy Vedugopal, Judy Edwards, Mei Ling, and the members of the MRV team. We will be sending everyone who's attended tonight a survey in coming weeks, and we'd really value your honest feedback about the nature of this session, the timing, the format. If there's anything you can convey, that would be very helpful to us. As you know, we have 3 more sessions coming up over the next 4 weeks. Everyone is very welcome. Even if you don't have Fanconi anemia, you are very welcome at the Fanconi anemia session. It's truly the more the merrier, so please advertise it far and wide to your family and friends, and if you're a hospital worker, your colleagues. And with that, I will draw the evening to a close and thank everyone for their presentations tonight. And thank you to all the attendees for dialing in. So thank you very much, everyone.
Thank you.
Thank you, Lucy. Thank you, everybody. Well done.
Thank you all.